All right, we are live on YouTube and now officially recording.
Okay. Hello, everybody. Welcome back. Um, Meeting is being taped and recorded. Got that disclosure out of the way. Before we dive into the agenda, I'll give you a little update about recent things I've been doing, just for awareness. I had the opportunity to recently attend the Telcare's 60th anniversary celebration, where we had the opportunity to talk with frontline workers about some of the work that they do. They do incredible work with folks that are stepping out of the state hospital and provide secure residential, and it was really lovely to be a part of that. Um, I also was able to attend a meeting by the Balmer Institute to learn more about the behavioral health program that they're doing and prioritizing early intervention and youth workers. So it's been exciting. Our last meeting was dedicated to peers, and so today's meeting will focus on providers in youth practice settings. And during the series, we'll take a closer look at each of the profession types and then hear from experts about some of the things that are important to be thinking about in successful strategies. During the presentation, if people want to hold their questions, we're going to have a brief dedicated discussion time. And then the fabulous Amy Baker is going to do some unpacking of the different providers in the youth practice settings, because while the licensure pathway may be similar, some of the settings require different regulations and things that make this unique. And so that will also take a little bit longer than usual because there's just more to know. Let's see. And then after that, we'll hear from Andrew Grover, the Executive Director of Youth Villages. Chad Westfall. Am I saying it right, Chad? Yes?
The PH is an F, Westfall. You did
Westfall.
well.
Okay. Westfall from Youth Villages, where I've had the opportunity to visit. Then we'll take a break in maybe 15 minutes. We'll see how we're doing. You know how that goes. And then we'll hear from Tony Vizina. And then we'll wrap this up with a group discussion. And so with that, it's time to kick it over to Amy Baker.
Thank you, First Lady. So I want to talk a little bit about the child and family landscape in Oregon. While there's a lot of similarities with the adult system, it has its own unique features and strengths and sometimes barriers and challenges. Next slide, please. So let's start with the obvious. People go to work in child and family and youth services often because they love kids, and they're doing it from a place of heartfelt desire to make the world a better place. And in full disclosure, Clara Hughes is a speed skater, and I have no idea why she made this quote, but it seemed to capture why it is that people go into the profession, and that can sometimes be a really big strength. And it's also an attribute that providers also need to take time to help shape and help the workforce be better equipped to serve the child and family population. Next slide, please. So in addition to things that you might learn in graduate school as you're becoming in graduate school, or you're in a credentialing program, or you're gaining experience in the field, there are different things that you need to know in terms of how to work with the child and family population. For instance, a good understanding of appropriate child and adolescent development, that we never want to be in a position where we're diagnosing someone just because they're not quite at the right developmental stage. Developmentally appropriate communication, that's a really fancy way of saying you have to know how to talk to kids. And if you talk to them like you're an adult and they're a kid, they're going to see right through you, which is one of my favorite things about working with kids, is that they do, in fact, see right through you. But it's not just about how you talk and work with kids. Kids are not these little islands. They come with families, and you also have to be able to understand how to work with family dynamics in order to help the child within their own family system. And the commonly held secret that all parents are terrified that they're screwing up their kids, which I don't know why that's a secret, because literally every parent I've ever met has held that fear, that when you're engaging with families, you have to figure out how to get around that secret fear and that sense of shame we all carry when we think, oh, I might not be doing the right thing. So it's the how to engage families as partners around creating change for kids within both family systems as well as school systems and the community. Additionally, like understanding how systemic oppression and trauma and intergenerational trauma kind of play out in a kid's life. Sometimes you might think that you're dealing with something that meets diagnostic criteria, but you're really dealing with a reaction to certain situations or triggers. So being able to tease that out. And then lastly, I would say I think the thing that's really challenging about working with youth is that they're so vulnerable. And when you're working with a population that is so vulnerable, it tends to really kind of tug at your heartstrings. And so developing a sense of resilience and self-awareness so that you're able to stay separate enough from the work that you can really like bringing your heart to the work, but staying separate enough that you can remain neutral is a real challenge. Next slide, please. So I'm not going to go through all of the credentialing types that we have done in the last several sessions, but I do want to warn you that there is going to be a quiz at the end of the Talent Council to see if you have memorized all of these credentials. And the important piece to this is that they're all largely the same as the adult system. Workers fall under the same credentialing and licensure types. There's some additional requirements if you're going to be a child psychiatrist, but largely it's the same. Next slide, please. So this is where our workforce works, and it's starts on the least intensive side, and that's really around prevention and early intervention. And so those types of activities might look like screening in a primary care office or supports in a school system. Early intervention might be brief intervention that happens for a child who's starting to have some behavioral health challenges. Outpatient is community settings largely. Intensive outpatient, we tend to see more like intensive in-home community-based services. That could be like IIBHT or intensive case management. And then as we go up the paradigm, we've got intensive community-based services, and that includes licensed residential facilities. It can include 24/7 in-home services as well as wraparound services, which often look at bringing cross-system involvement to support kids with high needs. And then lastly, we have hospital and psychiatric inpatient. And in Oregon, that's acute care. And it is also, it's acute care, and it's also the secure inpatient units. We have a SCIP program and a SAPE program. And I think part of the message around this is that because kids are so vulnerable, sometimes we as a system end up trying to put extra measures in place to try to keep them safe. And I think you'll hear from Chad and some of the others that there's some Oregon's pretty heavily regulated when it comes to residential care for kids. And that's like in particular has to do with some restraints and seclusions have the potential to get categorized as child abuse if they're done improperly. And what that means is that if you have a worker who's on the front lines in a residential facility, and they do an improper restraint, they could have a founded abuse complaint, and that could affect their future career. And so it's a consideration that providers have to take into account when they recruit and train workforce around understanding the real risks of working with kids facility-based care. And I think again, because kids are so vulnerable, sometimes humans have this funny thing of doing this paradox where we're trying really hard to do one thing, and then we actually make the other thing happen. And so one of the other effects that we're seeing is that we're having to develop more secure inpatient units because psychiatric residential facilities can't serve kids with the same high intensity behavior that they used to be able to prior to the regulatory environment really setting in. Next slide, please. And so this really spells that out. So for residential providers, they're both licensed by OHA and DHS. DHS because they're considered a child caring agency. In addition to being licensed by OHA and DHS, they're also required to be accredited. So national accreditation, which includes JACO, CARF, and I think COA is also included in there. And so that regulates the staffing and all the things that go into like every aspect of care when kids are in residential programs, including IEPs and all kinds of inspections and audits. I think Chad will talk about all the different entities in Oregon that have oversight over his programming. Next slide, please. And so again, to ground this in the Talent Council, you see the child, family, and school social workers that we have a projected gap of 1,140 by 2034. And I think that it has a lot to do with all the reasons that I just talked about, but I think we'll hear more from our providers around kind of what their successes have been around recruitment and retention and what some of the barriers and challenges will be. Next slide, please.
Great job, Amy.
Thank you.
Any questions? Okay. Okay. And so next I'll turn the floor over to Andrew Grover, Executive Director of Youth Villages, as we move into successful strategies. Andrew began his pursuit in social services as a child, having come from a troubled home and saw life on the streets, in residential programs, foster care, and juvenile corrections. At an early age, he decided to dedicate his career to helping kids like himself. And that journey began working directly with at-risk youth and families in residential and in-home settings. He holds a BA in psychology and has a master's of public health. Andrew, we're so glad that you're here with us today.
Oh, well, thank you, First Lady, and thank you to to the council for having me. I didn't know you were going to actually read that bio. Maybe someone found it on the interwebs out there, but that's wonderful. Thank you.
You're welcome. Do you have anything you'd like to add?
Well, I'll just kind of jump in with with my remarks. Nothing to add to that. Thank you very much. I've been living in Oregon since 1996, and I've been working in the children's behavioral health space that entire time. So I'm kind of getting to be one of the gray-haired people around here, and so I'm going to share some of my thoughts on recruitment and retention from our own perspective. But let me go ahead and pull up. I think you all can. So wait, now you can't see it yet. I gotta click this. Now I think you can see it, right? Can you see my thing? Okay. So let's see. I gotta get over here, and here we go. A little bit about youth villages in Oregon, just to give you some context. We've been serving Oregon's youth and families since 2011. We started here with the merger with what was then the Christie School, or Christie Care. So those of you who know about that program, and I actually worked there, and we, actively sought this merger out to do the kinds of things that we're doing today. Since then, we've worked with about 4,500 of Oregon's youth and families. You can see in the next couple numbers there, a little over 3,000 of them with our intensive in-home services. And then about 1,500, going on 1,500 in our transition age youth services. Those are all community-based. So when I'm talking to you today, I'm talking from a community-based kind of perspective. At this moment, we're working with 380 families. We're growing pretty quickly. Here's a little bit about where we do our work. If you draw a circle around any of these offices, that is about a 1-hour drive time. That's sort of the catchment area for each of those offices. So in Bend, we're really going as far south as Lapine and as far north as Madras. We go to Prineville. We send our counselors out into the community. We don't ask families to come to us. So we're covering 10 or 11 counties right here. And then we're really happy to announce that literally next month, we're going to start seeing kiddos and families in Tillamook and Lincoln counties. So that's exciting for us. We've so far had a pretty warm welcome with that whole implementation. It's helpful for you to know that we have a national scope. So everything that I talk to you about is really informed by our experience in 19 other states where we deliver direct services. And then those 9 other states on here, or maybe there's only 8 because this map isn't caught up. Those are partner states where we're training other providers to implement some of the models that we've developed. And then you can see a couple states there, Ohio and Louisiana, where we're a hybrid. We do direct services, and then other folks do some of the work that we've developed. Oh, last thing I'll say about this one, you can see on the right, that pie chart, the vast majority of what we do in that gray is in-home services, and the red is transition age youth services. And that's our current census. So across the country, we're working with about 12,000 families at any given time. Okay, so I'm going to talk a couple minutes about recruitment successes and challenges. I'm going to intentionally keep it as high level as I can, but I'm happy to have further discussion, brainstorming questions and responses probably, because if I had the answers, we wouldn't need a committee. We wouldn't need a council like this. So it's a complicated problem that we're undertaking. Here are some of the successes that we've seen. And I doubt if this is any brand new thinking for anyone, but we do paid relocation, and we actively seek out people who are in market for these kinds of jobs, social services, behavioral health, across the country. I feel like I love Oregon. I picked it. I'm raising my family here. And I feel like we've got to really move to the mindset of we've got something special and wonderful here. We want you to come and be a part of it. And we've got to start working to sell that vision to people, because the workforce is shrinking. The generation of people that came before all of us was a lot bigger than the generation that we're a part of and thereafter. So the workforce is shrinking right at the same time as the need is going up. So really working to attract clinicians from other states has been a big push for us. Right now, we've got about 110 staff, probably 30 to 35% of them we recruited from other states. Okay, team-based care models. That has been really helpful because of something that I'll talk about later. But when we work with young people who have really significant challenges, families who are really struggling to stay safe, to stay together, some days life and death kinds of things. And so having the ability to have a highly trained, highly educated, maybe licensed clinician working alongside a bachelor's level clinician, working alongside peer and family support partners, kind of everybody filling the kinds of roles and competencies that they can do, rather than expecting all highly trained and educated, people to do everything all the time. That has been a big thing. This third one that I put on here was investing in the future. We've put a lot into university partnerships. It's not the kind of thing that pays off tomorrow. You can't send your staff to a job fair at a college and expect something to happen, at least not that's going to really move the needle. But if you build relationships over time, we just promoted someone into one of our senior leadership positions that literally started in our intern program about 6 years ago. So that was a real win. And then obviously, as I just mentioned, internship programs have been really helpful. They get in the door, they appreciate the training that we provide, the supervision and the oversight. And then if we do our jobs right, they want to stay, and oftentimes they do. So those have been some things that have really been helpful. Some challenges. Rigid credentialing requirements. I was trying to think of a really clean example that's easy to understand, but one is, in the Medicaid system, for example, you can't even complete a treatment plan unless you have a master's degree and have demonstrated competencies and all of that. And I understand that. But we could figure out ways to be a little more flexible in there and say, okay, well, someone needs to review and sign it, but someone else can actually produce it and develop it, provided it's done, well. I mean, that's just one concrete example, but the credentialing requirements. Competition is going to be an issue, for everyone. But competition in particular in the for-profit and government sector, in the nonprofit sector, we are often seeing the publicly funded behavioral health services are often seeing the youth and families who have the highest needs. And we often, and I think everybody knows this, are working with clinicians who have the least amount of experience. So what happens is we become the training ground, and then other people recruit our staff. And that's kind of like the cycle. And as long as that cycle goes on, it's going to be harder for people like our organization to compete with the full compensation package and job descriptions of other organizations. So that's just, I think you probably knew all of that, but I thought I'd put it all on a slide and talk a little bit about it. Okay, retention. This goes, I think, a little bit, into an area that kind of a statewide council may or may not have a whole lot of levers to pull. But in my own mind, and in many people in our organization and lots of others, I think it's increasingly creating the culture that people want to work in. That's the bottom line. And so how you do that and what you do, it's a nuanced thing, but it starts with leadership mindset. I've been reading a lot lately, and watching some stuff by Simon Sinek, the guy who did The Tipping Point. He did a whole bunch of other kinds of things. And he talks about how, and I think many people, know this and will ascribe to this, actually delivering it is a little bit trickier, but that leadership is fundamentally about relationships with people. It's fundamentally about continuing to learn and prioritize taking care of people. And if that's where your starting point is, then the things that flow from that will be good. And that's what we've tried to put into place. Our turnover at this point goes between 25 and 30% a year. And I still think that's way too high. Training, support, and supervision. Again, we're working with people who are often fresh out of school, don't have a lot of experience. So giving timely and relevant and substantive training is really important. Providing support if a new staff or any staff calls someone, doesn't matter who they, that person will answer the phone and will help them or will show up and help them in the way they need. And then just ongoing supervision to navigate the challenges. And those are things that are really obvious, but the way it's delivered, that's where it all comes down. Creating career paths for people so that they can see a way forward. And professional development opportunities, like we pay for people to get licensure. We do tuition reimbursement, things like this. So, okay, challenges again, I mentioned already, competition from other sectors. And the one thing that did come up as I was thinking about this is I do worry a little bit about our leadership pipeline. And I think about 10, 15, 20 years down the road, or even 5 years down the road. And, a lot of times what we see is we successfully recruit someone. They want to go into supervision or management of some sort, which we need people who are good at that. But they can't or won't because they still have 2,000 hours they need to get to secure their license. And so they say, I'd really just rather have all my hours be client facing, even though my preference would be to kind of use some of my skills to supervise, lead other people. So those are some of the challenges. Yeah, so that's really kind of the set of things I thought of as I was talking with Amy and getting prepared for this. I'm happy to elaborate on any of that or however you want to go from here.
Thank you so much. Yeah, let's first see what if people have questions.
Okay.
And
I see Liz.
yeah, Liz, go ahead.
And very politely.
Oh. I just had a quick question on the relocation stuff. Do you guys also pay for like changing over licensure and things like that to that state?
Yeah, anything licensure related, anything that makes it so that they can do the job we're asking them to do, we
Okay.
will. Or,
Cool.
yeah, those are two separate programs, though, licensure and relocation. But we would pay for someone to change their license, yes.
Yeah, to like the different state.
Yeah, and we've had a few people who have had to do that. And sometimes I think there's reciprocity coming soon. I don't know. People keep telling me that. I'm not tracking every detail, but
Yeah.
yes.
Cool. Thank you.
Robin?
Yeah, quick follow-up question to that. Are there certain roles that you do pay to bring folks over for?
Any full-time position. So we have very few part-time positions, but any full-time position we will pay to relocate that are in the program. We generally don't relocate administrative staff, but we would relocate any clinical staff person. Yeah, Julie?
Couple of questions. Do you find that your relocated folks stay with you? And the second question is, say a little bit more about how you create the culture for retention.
Yeah, so generally they do stay with us. As a rule, I'd say probably 2 to 3 years. And part of that is depending on how much money we give them to relocate, we ask them to enter into a contract to stay for a period of time. So there is that. We're not super high-handed about enforcing these things, but we want people to know from the outset that we're investing in you and we hope that you'll really invest in kind of learning and growing with us. I feel like leadership culture is a very difficult thing to define, but it's sort of like you know it when you see it. But I will say a couple other sort of nuts and bolts type things that are helpful. We, like many people, we do annual and periodic employee satisfaction things. But we do that through a third party that has it's called the Great Places to Work survey. And we're always striving to achieve that sort of status of being called a great place to work. We have, every year for the past, gosh, I don't know, 10 years. But in that data that we get, we read every single comment, we analyze the data very deeply, and we always do something to build on it, to improve, to kind of show that we're listening. And so that's one thing. It's sort of kind of low-hanging fruit. But the other one that I think is really meaningful is stay interviews. We do stay interviews very routinely. And we want to know sort of, because a lot of times you see in these fields, the people who are having the most problems as an employee are the ones who get all the attention. And that's not because they're bad actors, it's just because they're struggling and they need help. But the people who are just quietly going about their job and doing a good job, we want to sit down with them. We want to know, what is it that you really like about working here? What is it that you don't like so much? When was the last time you thought about leaving? Is there anything I can do to, prevent you from, thinking that again? It's those kinds of things. And you got to do that with a real relationship with people. I sort of mentioned that, leadership is fundamentally about relationships. You can't have somebody just sitting down, with a clipboard and going through a list of questions. It's got to be a sincere, felt sense kind of a thing. And it's possible that the generation of people that are coming into the workforce and are here now, want to connect with people. The days of transactional employment are just behind us. That's gone. This is a relational employment kind of a culture.
You are so right. I love the stay surveys. That's awesome.
Yeah. Ebony.
Sorry, everyone, for being off camera. I actually have walking pneumonia. I just found out, so
Oh,
I'm
Oh,
here.
no.
I appreciate what you just brought forward, Andrew, just because I think that one of the things I think that our system has to be intentional about and solve for is, how do we bring forward how do we support staff in present day, in modern day? I think I constantly think about before the pandemic when I would have staff and or even middle leaders that would ask to work from home a certain percentage of the day, and I would say of course not, but I was stuck in my old thinking, and it took the pandemic to realize, like, oh wow, like there are creative and innovative things that we can do when it makes sense. But I just think that, like, how do we continue to push ourselves in the areas that I think that we have blinders on that sometimes we don't realize? And so yeah, like this is a different generation and different needs.
for sure. The other things I would say, and then I see Jamie's got her hand and I'm probably out of time, but uh, there's this other concept of, again, I mentioned Simon Sinek earlier just because I just recently read some stuff by him, but he calls it mattering. Like, ensure that you notice people, you understand what's important to them, and you make sure that you're aware, that they know you're aware of that and that you care about it. Like, he calls it mattering, he calls it noticing, things like that. And I think it's really impactful, but nuanced. It's kind of walking around. In my graduate program, some leader, I think he was from OHSU, came through and said, I do this thing called managing by walking around. And he literally, that's just how we built relationships, just stopping by. Jamie, go ahead.
Oh yeah, I love this day interviews because it's something that we can all implement without significant cost in our relationships and supervision. And just curious about the relocation dollars. I love it that you're doing those for all positions. We've done them more sporadically, more, child psychiatrist based typically. just, I didn't know, and maybe you could send it to me, or if you feel comfortable saying more about the stay requirement. I get it that it may not be legally binding or whatever, but that it's an attempt. Is that 1 or 2 years? And then do you do a flat rate for relocation, or does it kind of matter where they're coming from? I just am curious about that. I'd love to be able to do it, but you can always.
We do a flat rate, but the term of the contract is longer. So if it's over $5,000, we're asking for something like 18 months or more. If it's under $5,000, then I think we ask for 12 months.
Okay. Cool. That's super
I'm
helpful.
happy to send that to you. It's not exactly a secret or anything.
I also just want to flag something that happened here so fluidly. I don't think we noticed it. And I know Andrew would agree with me and the other kids providers, is that Amy Baker from the governor's office just presented a perfectly fluid overview of the kids system, probably without even batting an eye or Google, like asking anyone or thinking twice. And just as a kids provider, to have someone in the governor's office that can bust that out so accurately and so fluidly means so much to us to feel that representation for kids providers. And so I just want to give a moment to pause to appreciate Amy's presentation.
Here, I couldn't agree more.
Agreed.
Well, thank you all. I'm happy to, connect with any of you outside of here. And I appreciate your time.
Thank you so much, Andrew. I saw eyes light up. I think there's questions about contracts and how to do that. The stay interviews, it was just, you could see people's faces. Whatever you feel comfortable sharing, we can get out to the listener. But I think those are great, just incredible ideas. And this is a perfect example of best practices and opportunities to steal and learn from each other. I think there's probably some other questions that we're just not going to have time for, but stay tuned, because I think there's a couple more follow-ups that I might have around how we compare with some other states.
That's wonderful. I'd be happy to help.
Okay. Thank you again. All right. Now, Chad, I'm going to turn it over to you. I'm going to talk about you for a second, though. Chad Westfall is the president and CEO of Looking Glass Family Services. And under his leadership, Looking Glass has expanded its program to include behavioral health, substance use support, basic needs assistance, juvenile justice, education, youth development, and workforce readiness. I really enjoyed visiting Looking Glass earlier this year and heard from their incredible staff. And when I say incredible staff, I mean incredible, dedicated, long-term staff who have seen a lot and have stuck around. And so and I want to echo everything that Amy Baker said around it being hard work and people being super dedicated. And so we'll look forward for Chad to tell us more. The other thing is I hadn't spent much time in children's residential, and I thought what was very interesting to me is what I was used to in adult residential when people walk into a smaller setting can just feel really different versus if you're used to working in the adult system, that feels sort of normalized. Okay.
Thank you, First Lady. And our team is still talking about your visit, by the way.
They're great.
I'm going to pull something up. Is everyone hearing me okay? And are you seeing that?
Yes.
Well, Andrew was smarter than me. He sent in a bio. I didn't do that, but I'll give you a brief history. My interest in behavioral health actually started when I would guesstimate I was 13 or 14 years old. And I say 13 because I come from a small town, Drain, Oregon, and my father was the high school principal. And back then, I'm dating myself, of course, there was no cell phones. Every conversation was in my living room or in the kitchen, whichever landline he happened to be on. And I overheard a lot of things that were pretty disturbing and required some explanation. Of course, being a kid, I had questions. I was sitting next to these kids in school, and he's talking to he didn't have an HR director. I think he had a secretary, and that was it, someone that handled reception, but he handled pretty much everything else, including behaviors and in-home challenges that resulted from those behaviors. And so I heard a lot of things And I asked a lot of questions, and I knew then that I would be working with youth at some point or another. And it started in just sports camps, but then my first real job was when I was attending Southern Oregon State College at the time. I think it was 1993, and then when I graduated in 95, it had become Southern Oregon University. And I worked at a local shelter and then a residential program called Lithia Springs, and then made my way to Portland, where I met Andrew Grover. He and I crossed paths at the Christie School. And the rest is history. I've been at Looking Glass now for 18 years, and thank you for that introduction, First Lady. We've had a lot of growth in all the right ways. We've been really responsive to our community. And I'm going to get going with the slides here. So this is our 4 service categories. We have about 370 employees, and we are performing services in 4 sectors: education services, homeless services, and outpatient and residential services. I'll focus on those 2 today. This is a little bit more detailed look of what we're doing. You can see our homeless services is quite a continuum, from outreach to drop-in centers to shelters to housing programs. We serve under 18, also 18 to 25. That's really important. You're not really an adult developmentally, especially the young people we're working with just because you turned 18. We've got 2 24/7 hotlines, and this reads sex trafficking prevention program. It is, but it probably should just read trafficking. Because there are other forms of trafficking that we address in our community. Education services, we have 5 different schools. We also have an independent living program and a trades program. And then I want to circle this here, outpatient services, while I'm a terrible drawer, because it is embedded in every program that we have in these 2 categories. Between outpatient, education, and homeless services, they're all Lane County. And then over here are residential services. That is statewide services. Our youth come from all over the state of Oregon. And I should mention, we're probably serving anywhere between 4,000 and 5,000 young people and their families a year. So let's jump into successes for recruitment and retention. This is a combination of outpatient and residential, and I'll highlight them as I go along. I can't say that we today had a lot of contribution to this, but we have sustained our history and our reputation, the recognition that we get. Looking Glass was formed in 1970 with a relationship, a healthy one, of course, between a homeless child and a medical professional in our community who purchased a home that became a shelter. And then today we are what you just saw on the previous slide. That doesn't help a lot with retention as much as it does recruitment. When young people, and I say that because that's pretty much the base of the workforce that we have, when they're looking for work after education, they're going to know Looking Glass, and if they want to work with youth, we're probably going to get an interview. And so I really am happy about that piece that I inherited, and working hard we all are working hard to continue it. Our administrative team, our structure is myself as the CEO, but I have 6 vice presidents, marketing and development, human resources vice president, finance vice president, and then 2 operations vice presidents. 5 of them worked in the programs. And I don't just mean might have been a therapist in a residential program, but didn't really get into the trenches of the care that is provided in those facilities. They all worked in the trenches, and those weren't just lucky hires. Oh, they are, I guess, a little bit. Very intentional. I've worked for several organizations, and not all, but a lot of the administrative team had never been in the programs doing the work. You don't find a lot of Andrews that actually lived the work and maybe did the work as well. It's rare. And for us to have 5 of our 6 especially our two VPs that oversee the operations, be able to communicate in the same language as the staff that are doing the work, that are struggling. We've been there. We've done it all. PTO accrual, this is specific to our outpatient work. When we bring on a paid intern, we let them start accruing PTO right away. And so if and when they become an employee, they've already got quite a bank built up. And a lot of them, this has really helped with us retaining them post-internship and becoming our clinicians. But a lot of them will take that PTO and take a little celebratory break and then come back and hit the ground running. So I'm very glad that we made that adjustment. That was about 2 years ago, and we're seeing it pay off. And I'm not going to go back to that screen, but you saw 26 bullets that represented our programs, our services, and all the locations. There's a range of positions in our continuum. You might enter as a homeless youth service provider, and then 2 years later, you might be working in one of our residential programs post promotion, or you just might have transferred because it was a better fit for you, or vice versa. You might go into outpatient and be a peer support specialist or a skill builder. And we also have non-license required positions in our alternative education world, especially in the trades programs and independent living programs. Intensive onboarding. I have this on here because it's difficult, it's long. We have all the required trainings that we have to perform as a licensed provider, but we go beyond that. And I'll give you an example. Right now, we're developing a training that just breaks down our budget, our agency budget. When you have 4 service sectors, you also have 4 completely different funding streams, and not all of them are equal. And you might wonder, and it has come up, like, why are they getting paid this wage over at this program area and I'm getting this wage in my Those things come up all the time, and we're responding to that. We're just going to have a training and break it down, be real transparent about our limitations, but also where we can be flexible. Peer integration, our attitude towards peer staff, those with lived experience, some people use the term lived expertise, is that it's invaluable. And the reason why we look at it that way, and we don't just communicate it, we actually put it into job descriptions as a preferred, is because they have something that can't be taught. And there was a time, again, you know my history, that I've done the work where people would use terminology like, what are we doing here? Why would we have somebody? It's like the blind leading the blind, is what they would say. That's the exact opposite of how we look at it, and we're living it, and it's been wonderful. These folks come in, and when we combine what can't be taught, they just have it, they experienced it, with what can be taught, the policy and procedures that come with national accreditation, licensing, and other certifications, and practices that fall under those umbrellas. When you combine the two together, you have an incredible employee. And we're really appreciative of the culture that we've set up there. And the youth are the ones that are benefiting the most, of course. Andrew already mentioned this. It's huge. Connections to local colleges and universities. University of Oregon, Bushnell. We see it in our nursing hires, and we see it in our clinical hires. Competitive pay and benefits, but here's the key part: relative to local peer agencies. We also do stat bonuses, and what I mean by that is we have a tiered system of compensation. So you could be a clinician in our outpatient world and maybe have 20 clients on your caseload and do just fine. That's your balance. That's where you want to be, and you can still work at Looking Glass. But you probably would get bonuses that are on the lower tier level versus someone that has a 35 to 40 caseload and hits all of their stats and is doing well. They're going to be a higher tiered bonus. But the key there is you can excel and exceed and be compensated for that. But if you don't, it's not like you have to go. There's another place for you that is more relaxed and still really important to retaining them. Telehealth goes without saying. Most of our clinicians don't want to do it. They like to do the in-person. Most of our clients don't want to do it. They like to do the in-person. But there is a group that does appreciate that. And a lot of them are rural, the clients I'm speaking of, but some of them are rural clinicians that live far away and would prefer to do telehealth. And we're able to support that. This one I put down because the paper world is gone. which is great. But you don't really have a backup if systems go down. You need to have a team that can support it. And in the corporate world, they're going to pay a lot better than us. And a lot of IT folks can work remotely and get compensated. We had to invest in it, but we have a strong IT team and we have a strong maintenance team. And residential in particular, outpatient doesn't experience this much. They're not going to have young people kicking their walls on an everyday basis and breaking things. But in the residential world, that happens a lot. And you can't have that just be put aside until maintenance gets to it. That has to be repaired sometimes within, hours, but never more than 24 hours. We have to have somebody there to do that. This really helps with retention. Nobody wants to work in an environment that physically is unattractive. So I really respect both of those teams and I'm happy that we have who we have, but it's, again, you got to pay for it. Professional development, supervision. Andrew touched on this already. We take supervision very seriously. And we also do the stay interviews and exit interviews. And those are, the stay interviews obviously are not confidential. You're sitting there right in front of them. The exit interviews go straight to me. And they can check a box whether they want their supervisor to view it or not. And it only gets sent to me, and then I review those and am able to handle them confidentially as required. Internal trainings. Our entire outpatient team supports all other programs at Looking Glass. Our residential teams and our homeless teams and our education teams. Those are the most highly educated people that we have. We have about 40 clinicians. We have 8 clinical supervisors that oversee that team. And a lot of that team has become licensed themselves. And we're working our rear ends off to try to retain them.
Hey, Chad. So sorry to interrupt. This is Taylor, just doing a friendly time check.
Okay. How much do I got, Taylor?
I think you're close to time.
Wow. Okay. I'm going to skip everything here. Geography, Oregon's beautiful. Everybody knows that. And I'm going to stick with this one. Culture that strives to support cultural safety and staff of clients. We hired an equity consultant. Her name's Aisha Elliott. She's also known as Black Girl from Eugene. Obviously, she is from Eugene, knows our community, and her work with our teams is incredible. I've never worked for an agency that didn't have a cultural competency committee or check the box once a year because there was a training. But that's just, you could view that as virtue signaling. The work we're doing with her is entrenched in our agency, and the generation of staff we're hiring today isn't my generation. We thought we were culturally competent because we had an annual training. That's not the way it works today. And I wish I had more time because I would go into great detail with what we're doing with her. But I want you to see, these are our oversight bodies. We welcome it. I'm circling this because the Council on Accreditation was the only oversight body that would accredit our homeless youth services and our education services. The other oversight bodies would only do our clinical work. And that shows you our attitude towards that. Here's the barriers: regulatory environment, increased acuity, emergency discharges, length of stay, cost of insurance. That diversity work isn't free, by the way, but we're going to do it. Economic considerations, reimbursement rates. I don't think any of this is going to be new to you all. And I'll leave it up here. I'll go back to it in a moment because I think I'm out of time, and I will jump on any questions that you have. Here's my recommendations. I'm just letting you look at it. When's the last time you saw a commercial of a direct care staff in a residential program having a breakthrough moment with a kid? I would guess never, but it happens. And thank you, First Lady, and all of you on the council for your work.
Thank you so much. I don't know who is first, Liz or Julie.
I'm going to jump in. I'm not sure how youth rates work because I don't work in that space, but how do you make margin when you're giving differential tiers to folks that perform better? Because that's something I want to solve for my workforce, and my rates just don't allow that. So how do you do that?
Well, the higher tiers, are you hearing me okay, Julie?
Yeah, yeah.
The higher tiers are pretty hard to achieve. And of course, that's the higher payout. And I'll tell you, we used to have our profit loss margin was something that we really depended on because those monies are unrestricted dollars. And so what we did was we built up other service areas in our agency that didn't need backup support from unrestricted dollars. And I'll tell you right now, our outpatient program does not produce a profit at all. And
Neither
it's
does ours.
because of our efforts to retain them.
Yeah. Yeah. Thank you.
Mercedes, you're muted.
I wanted to ask kind of two questions in one. The safety aspect. So one, what are you guys doing to like provide safety for your staff? And how are you guys addressing like what I'm seeing a lot in crisis is parents being out of options because their kids are too violent to be in programs. So they're being sent home, but then being told like then younger siblings are at risk, the parents are at risk, and they're being told that if they don't allow the kid to come home, they'll be charged with abandonment. So like are you guys seeing that? Are you running into that and kind of safety? Just what's going on there for you all?
Liz, our entire residential service array is because of what you just said. Because those young people end up on the radar of child welfare and they do not have enough placement options. And so they contracted directly with us as a provider, and they hadn't done that in the past. All of their contracts were behavioral rehabilitation services, and we were the first psychiatric residential treatment service contract they ever established because they needed help in the moment, no matter what the hour of day was, because these young people were winding up in the hospital with no step down options other than hotels or out of state placements.
Yeah. For that program, does the parent have to have given up guardianship?
No,
Okay.
not always the case.
Okay.
We've had both, and I will tell you, guardianship still intact is the rarest of the two sides, but we have had it.
Okay, thank you.
Thank you. And then Ebony will have to be the last question.
All right, thank you, First Lady. I appreciated on the challenges and barriers slide, it named a punitive regulatory environment. And, I'm super interested in, while I'm at OHA and I'm doing my part, really want to work to undo that. And so can you just give some examples of what, you mean by punitive, just so that we can have some explicit examples of that?
Yeah, Ebony, thank you. I'm going to tell you this with some guilt, but this summer, I coach my son in Little League. My oldest son is 9 years old. And this summer we're driving home and he's going through a phase of I want to be like dad, which is wonderful. Like I love it. It's probably going to end in like a week. It could end tonight. But he asked about what I do, wanted to see my office, and and I told him. And what I had in the back of my mind is here I am, his coach. And let's just say, I mean, we have years to go now, but let's just say he grows up and this is the environment that still exists when he gets to that point of wanting to join the workforce and he joins behavioral health and wants to be in the residential environment. There's a chance that he wouldn't be able to coach Little League if he did a accidental or wrongful restraint, if he was neglectful. Those are things that can go on your record. Your career is done, and it can go even outside of that career field. And did I have that conversation with him? No. But did I jump with excitement like a typical dad would when their kid wants to, be like them when they grow up? No, I was a little more filtered than I otherwise would have been. And it frustrated me that I couldn't do that because 20 years ago, even less than that, 15, I'm having a completely different response. They were both positive responses, don't get me wrong, but one would have had much more excitement behind it.
If I could say just super quickly, part of that is because the rules around holds and seclusion aren't just rules, they're also criteria for a child abuse. And so all the little nuances of every little rule that you're like, we're trying to follow these rules, that's incredible. It's not just a rule that licensing is going to check in with you about, it's a child abuse finding. And so if you forget a documentation, a training is a day late, those are also child abuse findings. And so let's let rules be rules and abuse be abuse. And that's the dream, I think, for protecting our staff and helping us employ kids like Chad's son someday.
Thank you, everyone.
Absolutely. Thank you so, so much. We're gonna have, we'll have, there's still time for a discussion in this agenda. And I think it will be, I think there's a lot of discussion to be had. And so I'm looking forward to that portion. Presenters, feel free to remain. I think that could be really helpful. How about do people want to do a 10-minute break? We could do 10, we could do 15. 10, okay.
That's cool.
Yes, it's easier to track in our minds too. If we want to go from it's 3:03, so if we want to come back at 3:13, that would be fantastic. Okay, I'm looking at Taylor. Taylor, we're ready? Woohoo! All right. Hope everybody got a snack or drink water, got to go to the bathroom. Hopefully didn't have a hard phone call. Welcome back. Next up, we're going to hear from Tony Vizina. Tony is the co-founder / executive director of Fourth Dimension Recovery. And it's a pioneering youth nonprofit recovery center in Portland, Oregon. Tony's dedicated his life to empowering young people in recovery through peer mentoring, advocacy, and community support. Under Tony's leadership, 4D is America's first youth-led recovery community organization that serves over 500 young people. Again, Tony has just been a pioneer. He has made recovery hip. He has engaged so many young people. It's really great to have you here to talk about best practices. All right, Tony, are you ready to go?
I am ready to go. Can you guys hear me?
We certainly can.
Okay, I got Dr. Krapser here with me. He's our clinical director.
Fantastic.
And 4D got big enough, I was able to hire a doctor for academic credibility and to legitimize my thoughts and opinions. So he's here today to legitimize me. No, I'm just kidding. I got Dr. Krapser here with me. Nick, do you want to introduce yourself real quick while I boot this up?
Yeah, good afternoon, everybody. I'm Nick Krapser. I'm the Director of Behavioral Health and Recovery Services at 4D. I've been with 4D for going on 2 years now. Before that, I spent most of my career working with people that are either going into incarceration or coming out of incarceration. So I have around 18 and a half or so years of working with that demographic.
Great. And then can you guys see my presentation? We're good to go. Okay, switching between all the different online options sometimes drives me crazy. Okay, so today, we're going to talk a little bit about 4D. I'm not going to spend a lot of time on it. I know we're busy. I'll get into the crux of why I was asked to be here. But, we're a recovery organization. We were founded in 2013 when I first got sober, and we're young people hanging out in a warehouse. Some people found us who were professionals in long-term recovery, and they helped coach us and mentor us as our nonprofit. We've been expanding ever since. This is sort of our service array here. We got about 150 staff, give or take. Primarily been a peer support organization, but we do offer some housing. Our claim to fame is really these recovery centers, these drop-in recovery centers, kind of post-treatment, long-term support. We serve adolescents and young adults. We have some behavioral health treatment services, and then, we're pretty heavily focused on policy development, and just increasing access to substance use misuse services across the whole state. We're dedicated to that. We know we can't solve every problem. We know it takes people like all the people in here to solve these problems and support individuals. Nick, do you want to just talk quickly about our treatment structure?
Yeah, sure. So when we signed up to start providing services last year, we got our certificate of approval from the state right around October, the first week of October last year. So we've been providing treatment services for just about a little over a year now. And we are a co-occurring capable treatment center, which just means that we are able to provide substance use disorder, mental health, and problem gambling services to folks. And so our license is for young adults, or for adults and for adolescents.
Nick. This is our current capacity. I'm not going to spend a bunch of time going over it. It's mostly recovery services, drop-in centers where we got services from Vancouver, Washington, all the way down to Southern Oregon. We have one outpatient treatment facility in Gresham for young adults. We have one adolescent outpatient treatment facility in Portland. We're opening up a campus that's going to have residential outpatient detox, recovery drop-in services, family programming, educational services in conjunction with the recovery high schools. That's going to be for adolescents. That's set to open in March. We're in the construction phase. We'll see how it goes with permitting and all the other stuff you got to get through. And then on December 1st, we'll open up our adolescent outpatient / drop-in center co-located with Discovery Academy in Salem. So it's one building split in half, recovery high school on one side, 4D recovery, full service, outpatient is what I like to call it, services on the other side. And then we have outreach, engagement, some deflection services, and really, we want to engage people, intervene on substance use, stabilize them through treatment, and then provide them long-term support. So they're getting the whole continuum of care over time. Okay, some of the success we've had here, which you guys already talked about, it's professional development pathways for entry-level peers and site counselors. Really trying to align ourselves with the MACBO workforce career ladder. We have paid internships, really focused on getting CRMs, peers to be able to be CADCs and CADCs to be CADCs too. That's one of the most cost-effective and educationally expedient ways to increase our workforce. On the mental health side, it's a little more difficult. It takes longer because of educational requirements. But we have a lot of professional development opportunities across all our departments. We really encourage that. You got to grow your own. And then a lot of our staff were former clients, and that's all the way up our organizational structure, including to the director level. So really find the clients who really want to work here. They love our mission, getting them in, making them happy, giving them professional development opportunities. And then when it comes to recruitment efforts, what I've experienced is that leveraging our community has been more effective than using some other modern tools like Indeed. We seem to just have a better success when I'm reaching out to another executive director or reaching out to people in the field. We're putting on social media, we're shooting it out in our recovery centers. We're talking to people like through that way. It seems like one of the best ways to recruit people. But this also leads to like staff stealing sometimes, which is like it's a weird concept. I don't feel that way when our staff leave. It's like, oh, work where you want, go work where you're happy. You know what I mean? It's a big chunk of your life, but that does happen. We have pay differentials for adolescent and family specific staff. We've like had to do that, and I'll talk a little bit more about the challenges of that in a minute. But we've like had to do it to be able to recruit people and retain them. Some of the state recruitment and retention funds that came out were like really great. The bonuses, that we had. But what I experienced is that they were great in the short term, but they can lead to the staff stealing, and then some wage dissatisfaction among entry-level workers and supervisors. And I'm not saying we should change it. It's just something I noted. For like example, like a entry-level worker receives a recruitment and retention incentive, and then it's like almost comparable to the supervisor. And then the supervisor's like, what the heck? Like the people I'm supervising are making almost as much money as me. And I want more money, right? But it's not that simple across all our departments to be like, okay, we'll give you more money and you more money. I think Chad referenced it. It's like difficult. We have some constraints. And then after the bonus expires, the staff sort of feeling undervalued. And then there's another bonus at another agency. And so we kind of train them up and then they bounce to the next bonus. But we're also the recipients of that. So I guess from a system perspective, it kind of works to keep people in the field. But, it's just kind of an unintended consequence. For us, braiding funding, fee for service, grants, private donations is like essential in the adolescent space. It's sketchy because you don't know how long the grants are going to last. And so you have this operational dependence on this braided financial structure, but you don't know how long it's going to last, right? And so it's tough to make some decisions. Some of the state and technical assistance investments I've seen have been like super great, really around the free educational opportunities. Like Eric and like really Eric Martin from MacBo, he developed all those peer best practice manuals. Those have been like really great, and they're like open source and free, and trainers are out training people, and it's a great way to build competence in the field. And then some other agencies like Nick's got contracted to do this lived experience supervision training, and so he's out training people how to supervise peers and people lived experience, and those are just like great critical development opportunities for the general workforce. We got sort of a carceral to SUD employment pipeline going. Nick, could you talk a little bit about how you developed that?
Yeah, when I worked for the Department of Corrections for a number of years as the Behavioral Health Services Director, and started a program with at the penitentiary where we were able to find folks that had identified as being in recovery, and were able to sort of, I hate to use the word prove, but prove that they're in recovery by the fact that they had negative UAs for a period of time and they were attending, whatever they could to support that recovery. And we hired those people, trained them as recovery mentors, and started a recovery mentor program where people could volunteer to need services and identify that they needed to help with that. So they were able to get mentoring services from a certified recovery mentor. And Macro was great to work with to make sure that they were able to get the folks that we had in there institution specific certification. So they still had some steps to go through when they were released from the institution, but they were able to enjoy that credential while they were in there. And on top of that, we found some individuals that wanted greatly to become drug and alcohol counselors, and about a handful of those folks did the education and got the drug and alcohol credential. And when they're getting out, they're getting jobs in the field. And we've been very fortunate to, have that connection so that I could recruit some of those folks. And, Tony's going to talk about the challenges of some of that too. But it's nice. Those individuals most of the time would never have an opportunity to leave a situation like that and come out to a living wage job with insurance and health benefits and, the rest.
And they've been some of our best workers, to be honest with you. Okay, so then some of the challenges here. So when I was talking to Amy, and I'm new into the field with like licensure and, dealing with OHA and having to hire more educated folks. But when I was launching the adolescent treatment services, what I really found was two buckets of people that were options for us. You have these motivated individuals who lack the technical skills required to work with adolescents, both SUD and mental health. And that sort of resulted in these increased demands on leadership to provide oversight training to prevent various critical errors, And then I found qualified people who I couldn't talk into coming over to work for us, who had the adolescent and family chops, but they were like burnt out. They're like, I can't do it no more. Like, and I'm like, why? And they're like, well, there's the standard rates that don't pay for differentials. There's productivity demands. There's the managing inexperienced staff. There's the background check process. There's the agents, like trying to figure out the agencies and the licensing and them coming after you, and you're just trying to provide care. So those things, people were like burnt out. And I got lucky enough to get Nick, but I was starting to get a little desperate for a minute. I'd fundraised a bunch of money, promised a bunch of people I was going to do a bunch of stuff, and then I was having a really hard time recruiting people. And then the fee for service model limitations, the standard rates don't account for the pay differentials, the training requirements, the lower engagement, the travel, the engagement activities you need to get youth to the center. And then also there's some master level mental health internship billing problems that I'll talk about in the solution. The background check process is like a little bit of a nightmare, especially hiring people lived experience. Nick, can you just touch base on that?
Yeah, so the OHA background check unit has a pretty cut and dry process that you go through when you want to work with people that when you have access to mental health records, you got to go through their background check. The process has a list of disqualifying convictions and then a list of potentially disqualifying convictions. If it falls in the disqualifying list of convictions, pretty cut and dry, you don't get to do that's it. You don't get to participate in that. But if it's in a potentially disqualifying category, they need to work with, get some letters from, folks and somebody to vouch for you. And it's an arduous process that can take 6-8 weeks. And at the same time, you're not allowed to put those people on the front line to work. They need to be supervised until they pass that background check. And we've been in situations very recently where we had 8 weeks where we're waiting to get a background check approved, and we have to pay the person, and they're not doing anything but shadowing during that process.
Yeah, and then we talked about the competition, multi-agency fragmentation. I want to touch on that. But Nick, can you talk about the internship supervision issues with the licensing boards?
Yeah, so like for instance, I'm an LPC, licensed professional counselor. That's my educational background was focused there before I received my PhD. So with the Oregon Board of Licensed Professional Counselors and Therapists, I'm a licensed supervisor to supervise marriage and family therapists and LPCs. But I have a PhD in psychology. If a person comes out of an MSW program and they want to work at our agency, I cannot supervise them. I can't supervise them. And I have to have an MSW in the organization that is a licensed clinical social worker to be able to provide the supervision for that individual. And conversely, the same thing happens if I was at LCSW and an LPC or somebody that was in that track as a LMFT came to the organization, I cannot provide that. They can't provide the supervision for me. And it just seems like it's a lot more of a barrier than it needs to be when we're working on the same type of thing. There seems to be some there should be some way to accommodate that. And then when we have individuals coming out of schools and they're in those final stages before they receive their master's degree, there's a whole nother layer of supervision that goes on top of that because of the school requiring a certain level of supervision. So there's additional requirements, and sometimes I don't meet that requirement, not because of anything other than the educational track that I chose was not through social work.
Yeah, thanks. That seems like maybe an easy one to fix, maybe not. I don't know. Okay, so here's some of our adolescent and family workforce recommendations. One is that everybody's going to agree with this: just increase the rate and coverage for adolescent and family services to accommodate the reduced engagement, transportation needs. We got to drive to pick kids up. Like we have to. We have struggle getting parents to bring them. They don't have parents. They can't make it. We need to like spend money on food and activities and stuff to sort of draw them in, they want Uber Eated food and all that stuff. We're trying to accommodate them, but that doesn't really get captured. And then the workforce pay differentials. Streamline the background check system, shorter timeline, revise qualifiers, and improve the communication with the background check unit. You don't have nobody to call from my understanding. You got to just wait to get a call from a random number at a random time, which makes it really difficult to just
An anonymous
people
number,
up.
not a random number, an anonymous blocked number. You have to wait for that call to come in, and you cannot communicate with anybody.
And then the adolescent and family workforce development continuum, really strengthen and expand specific incentives for youth and family workforce development, education, recruitment, and retention, with a specialized focus on QMHPs. That seems to be the biggest thorn in our side is the QMHPs. And then align incentives with the MACBO career ladder and include funding for targeted outreach by providers. And I don't mean to clients, I mean to workers. I don't know how you guys would do that, but like give us as an industry a tool to have people go out or do marketing, like Chad was saying, on TV. And it's like we need tools to go out and recruit people, go to colleges, stuff like that. Agency licensing alignment, improve coordination between OHA, ODHS to streamline integration of residential licensure. That could be difficult trying to get both the bodies in line with what you're trying to do. I experienced it just trying to get some architectural designs approved, trying to get them both approved by the two different agencies. Increase investments for adolescent focused education and behavioral health and family systems. Nick talked about the QMHP variants for interns. I guess standardized maybe is not the right word, but what I experienced recently is like we have the ability to self-credential for a master's level intern, but we don't have a guarantee that the CCO is going to reimburse you, right, for the service. And then we can get a variance from OHA, and there's something else that MacBone needs. And it's like, I got this qualified person who really wants to work with adolescents, and I want to hire them right now, and I want to pay them so that I can retain them later. I just need to make sure I can get paid because my profit margins are already so difficult on the adolescent side. So that seems like an easy fix, not super complicated, doesn't cost money. And then just overall increase educational requirements for co-occurring care in higher education settings. I was the president of Portland Community College, and I was unable to ever get like addiction and mental health training requirements or class requirements for various fields like nurses, allied health professionals, mental health. Like I could not institute that. And then so people are entering the workforce with a limited skill set, either like they're CADCs and they went that career ladder and they really understand addiction, but they don't have the mental health chops, or they're coming in with really great mental health experience, but they don't really have the addiction counseling chops. And so it creates a whole assortment of issues and training inside of the agency that could be reduced if they were just required to get some of that initial training through their educational pathway. And that is all for us.
Great job. Great job. To so now we're going to open it up. So we have questions and then discussions. And my guess is it might lead into both, like the questions might turn into discussion, and that's okay. And that's also why I thank you for the folks who had stayed, because I thought we would kind of just open it up. So I just want to say first, is it anything specific to the 4D presentation first? I want to, because I think I have one specific question for that I will go after the other two if it's specific. Chad, do you want to go first then?
Thanks, First Lady. It's not a question, but rather a comment to both you, Nick, and Tony. We run into the LMFT and social worker supervision issue all the time. And I don't know if you've experienced it yet, but when we lose one of them, we keep them on payroll and still use them. And they don't do a lot of hours for us, but because of the good relationship, the positive exit, we usually get a pretty decent rate. And we can talk offline, but just something to consider as people exit your agency, keeping them on just for supervision purposes. We've had good luck with that.
Thanks, Chad.
Todd, I think you're next.
I don't have a question, but I did want to correct one of the things that was said. I can't speak to the Board of Social Workers, but for the Board of Licensed Professional Counselors and Therapists, we accept supervisors from other mental health professions. We have multiple social workers. We have art therapists who serve as supervisors for our registered associates.
Can I follow up on that, Todd?
Yes.
I know that this hasn't not always been the case, correct? Because I feel like I remember when it happened.
It may have been a while ago. I've been here a year, and it has been that way for at least the entire year I've been here. I don't think that's a recent change. So I can't speak to what it may have been in the past, but I know at least for the last couple of years, because I've seen a couple of applications where folks have had non-LPC or non-LMFT supervisors.
Okay.
For licensure hours?
Correct.
Yeah, sorry, that was why I had my hand up too. Because LCSWs can supervise LPC and LMFT candidates. It's sort of I'm an LPC, and such a heartbreaker for me that we can't, it doesn't go the other way around, but they can supervise us. I
That's
think
it,
back in the
Jamie.
day, they had a stronger lobby. And I mean, back in the day, hospitals would hire LCSWs, but they wouldn't hire LPCs.
That's right.
That's changed a little bit in our culture now, go LPCs, but you could hire an LCSW to supervise LPC candidate.
My question was about this, and so I'll just keep going. Mary, do you want to go ahead?
Yeah, so it's interesting because psychologists can actually have a portion of their hours also supervised by LCSWs, LMFTs, anybody who is qualified in that discipline. So if other disciplines have some flexibility, that might, open the door a little bit for consideration on that.
Well, and can I ask, I think I understood two things. There was a question about in the variance conversation, there was a question about who can supervise who and under what licensure designation. But then there was a second point that I want to make sure I'm clear about. Then there was a question about they can be credentialed in the organization, but then there's an 08, but then whether or not that's credential is accepted by the CCO. Is that what I heard?
Yep.
Can you say a little bit more about that for maybe folks who don't get that, who don't
Nick,
understand?
can you take it? I just found out about it. I don't have the technical verbiage to describe it, but Nick does.
Yeah, so at some point in time, the CCO is going to verify the credential of the QMHP credential to make sure that that individual is qualified to see their members, right? And so if they get on the MACBO website, they don't see the individual on there as a QMHP, then they're not going to pay that reimbursement for that individual, right? So there is a provision that allows the individual to get, or the agency to get a variance through OHA that allows that person to technically be a QMHP, appear on the MACBO registry, and then they're essentially credentialed through the agency. And that's a period of a year that they can have that. And it was something that, it just came up for us, which is something that I learned about through MACBO and was able to just recently acquire for one of our folks that's in the tail end of her internship.
Yeah, and Van helped us navigate. I don't know, Van.
Yeah, I can jump in. So it's the mental health intern, the qualified mental health intern. And so MACBO doesn't have the authority to qualify mental health interns. Basically, it's somebody that has a qualifying bachelor's degree and they're in a qualifying graduate program that would make them a QMHP. So they're really a QMHA, but they want to work and bill as a QMHP. And under the OARs, they can be a mental health intern as long as they're enrolled in their graduate program and they have an agreement with the agency that they're working at. But there's no registry or database that's tracking these individuals. And the CCOs want a registry or database to look at to see, okay, this person actually is a mental health intern. So what people do is they go and request a variance to say, hey, we want to get a variance to make this person a QMHP. So it's not a variance for them to be a mental health intern because they already are a mental health intern. They already are a QMHP. It's just a variance for OHA to say this person's a QMHP under the mental health intern rules. And then they give it to us and then we put them on the registry. So it's this huge workaround. And a lot of agencies are doing it right now. And it just causes mass confusion because it doesn't make a lot of sense, especially from the QMHP's perspective. They don't understand what's going on. I mean, I went back and forth with Nick and Tony, and they're scratching their head trying to understand it, and it took me a long time to get it. But we just don't have the authority to do mental health interns.
Okay, I gotcha. Thank you, Summer.
Yes, thank you. So just to chime in on this little fun that we're all having with mental health interns, what we are getting just hammered with this. Since every CCO wants to do their own credentialing or has to, or however that played out, it has become a nightmare. Some of them are not accepting the licensing boards. This person's an LPC, this person's an LCSW. They're going through and digging up and doing their own whole investigation on all of their criminal backgrounds, demanding to know all the details of their expunged charges. It's a total nightmare. And it's not just our licensed folks. They're doing this to our peers and our KDACs as well. And then we have a different CCO that because of the mental health intern issue, they're not the ones who are, becoming like the FBI. But they won't, they need to see MACBO shows the QMHP, but their solution for our mental health interns that are in their last year of graduate school was to require that they all register as a QMHA through MACBO and a KDAC-R. And then we're supposed to provide documentation and have them explain that they're really a P. Just, saying.
Oh, wow. Thank you. That was a very helpful description. Thank you for walking us through that. Rachel, do you want to expand?
Thank you. So Summer, I'm not going to say that I followed all of that and could track it, so I'm glad you all can. But I need to make sure I heard you correctly. The CCOs aren't trusting the regulatory board's licensing or certification from our background check policies that are very stringent. That's really interesting. And it's, that has never happened at the Board of Nursing. I can't even imagine it. So very interesting.
Yep, I've offered to just send them the Orchard's background check proving that this person passed, stop harassing my staff and demanding that they write narratives about all of their past expunged charges and won't drop it.
Yeah, 100%. Everything that was just said, and it's happened. In fact, in the verbiage in the credentialing form, it says whether it's been expunged or not, you still need to explain it, which is illegal. When you get your expungement, it says to treat this as if it never happened.
I was just going to say we would not be following our rules if we took those into consideration. and a background check. So that is something very interesting that should be definitely looked into seriously.
Summer, this is Ebony. Let's talk offline, please.
Thank you.
Ebony, do you have more to say than that? Your hand's still raised.
No, I just want to understand the specificity and detail to look at what we can help support to bear your best around that on the OHA side.
Thank you. Okay. Now we have for the last 15 minutes, we sort of have time to open it up, talk about what we heard, talk about what we learned, have other follow-up questions. It's kind of up to the group. I have one specific, and then that I just wanted to ask, mostly for 4D around just I might be interested if this is something else people wondered about is I think when you're talking about kind of clinic-based recruitment, and I just wondered if other folks have experience doing that, because I'm wondering if it works the same in the recovery and the addiction space as it does in the mental health space. And so for people that are doing just mental health clinics, do you do any sort of like posting or anything like that?
I think Tony mentioned it when he was talking, but I've had so much luck posting something on Facebook and making it shareable, and then it's out there, and I start getting random messages from people that are like, "Oh, hey, I saw this through a friend," and that has been more productive than anything. It's like when we post an ad on Indeed, it's like we put the wrong address and phone number. There's no phone calls.
Our outpatient recruitment, First Lady, it is almost entirely reliant upon word of mouth and folks coming through the local programs and talking to their friends that they remember from a year back that were a year behind them.
Okay, thank you. This is the part where I'm going to stop talking and look at everybody awkwardly. It is.
I have a question kind of for all of you in different organizations, but kind of back to the safety aspect. I know I kind of already touched on this, but I just know that a lot of what I'm seeing of people burning out is the safety aspect, especially with kids, where there's all of these fears of, being charged, but also just fears of being harmed at the job. And I wonder what you all are doing to protect your staff while also serving the community, and like what ideas you all have to implement.
I can jump on that one first, Liz. To give you an example of the accuracy of what you just stated, our insurance provider estimated, because of the line of work we're in, that we might have anywhere between 13 and 15 injuries in this cycle. We've had 35. It's that intense, and obviously, you could immediately think, wow, what's going to happen to our rates? But you also have 35 people that got hurt. 35 people. Amy, I believe Amy Baker said it best. Like, these are caring people. Nobody signs up that doesn't have good intentions. They want to support young people in their lives and their families and help them return to the community, right? And then they're getting hurt. And that's just emotionally, like, how do you balance that? I want to care for people, and you just beat the hell out of me. And the response that we have is, one, you have to have emotional support in place. And I mentioned before the importance of having an administration that's done the work, that's been hit, that's been cussed at, that's been kicked, that's been spit on, been through all those rigors is helpful. We also have, employee assistance plans. We have our own wellness plan. The reality is that the regulatory environment is going to be around for some time. Um, and we had injuries even when I was working the floor, and we didn't have the same regulatory environment. Now those have like increased significantly, but they're not going to go away. And we do training and retraining and retraining. One of the things that we lost with the regulatory environment was an intervention model. Our crisis intervention model was taken away, and we were only allowed to use one of two other options. I was an instructor for PROACT, which is what we were using for 20 years, and I've been an instructor for crisis prevention, CPI, NCI. I was a dual instructor for that for 15 years, and one model's better than the other. But we're not able to use that, and so you have to make do. Fortunately, CPI came up with advanced trainings. Again, not funded, but we went to the advanced trainings. That has helped a little bit, but it's still not equal to our other model. And then our insurance provider forces us to do other things as well. Some things we haven't thought of. We have our own safety committee, and we have carve out times in our team meetings, and that's all you talk about. We have two carve out times. One is safety, and then the other one is our cultural awareness work. And every program area does that. But of course, the safety one in residential programs is critical. So we are doing our best, but it's not easy. I wish I had a great answer for you. Said, "Oh, we fixed that, Liz. It's not an issue anymore." It is an issue.
And I can kind of add from Trillium Family Services. Obviously, we run the State Hospital for Children and the historic Perry Center campus and the Children's Farm Home, being two really large residential programs. Because the regulatory system moved a lot of the other providers out of the space over the last 5 or 10 years, we really see that acuity condensed in our section in Chad's programs. And so whereas the acuity used to be spread out over more programs, programs that are admitting kids with significant aggression are less and less, and the amount of aggression that those programs are able to tolerate and manage safely to keep the kids safe, to keep the child safe, are few and far between. And then, as Chad said, right, like you are potentially going to be not only physically assaulted, but you will be investigated, whether it's opened formally or not. You will need to submit the documentation so that you can report yourself, because if you were hurt, well, what went wrong to cause that injury to yourself? And so you'll have to make sure all that documentation is in and clean, submit it for review. Then the Otis reviewers will look at it to see, if you could have done anything different to have prevented that injury to yourself from an abuse perspective. Of course, as Chad said, we're doing all this stuff around safety and debrief and a trauma-informed care where we're like trying to circle up around our staff, but we can't be there when the staff are interviewed and investigated by the Office of Investigation and Training, and they don't have legal representation in those meetings. And so if they say, for example, you know what, I should have, well, you have done their job for them, and now that is founded against you. If you offer any creative solutions or things you wish you would have done differently, that closes the case that, well, then you should have done that. There's not an allowance for this. Does this happen very often? No, the actual findings are very small, but the documentation that is submitted, the review of that documentation, the interview of your boss and your colleagues and the other people there that night, and the child is happening. Again, those cases are largely closing, but by the time you get to that point, you see why programs don't admit youth with violent behaviors, because you're going to be taking on this whole other body of not only, stress and safety issues, but in the investigation stuff on top of that, makes programs want to not take those admissions. Or if the aggression is spiking, to say, hey, mom and dad, like, you got to come and get your kid, which is so dangerous and catastrophic for families in the community to be feeling just kind of out in the cold now with a kid with really aggressive behavior. And so
Yeah.
that's just where we'd like to see that the rules around holds and abuse be related to holds and abuse, not just the rule. You can't just turn all rules. Could you imagine if like any clinical rule that we have to follow is also criteria for an abuse? If your treatment plan goals weren't measurable, that would be, like, you can't, it's not a one-for-one relationship. You can have rules that are not, copy and paste into the abuse criteria. So
Yeah, that's absolutely the issue for sure. And when kids are too violent to be getting, like to be in those settings, it's us that gets called in those times, you know, our crisis workers. And then it's like, what do we do in those moments too? Because we're going to be held liable. And it's just kind
absolutely
of
right.
a
Yes.
cycle.
Oh, am I on mute? Sorry, I don't know. My mouse is not working. Rachel, do you want to say something? You have your hand
Yeah, thank you. Hopefully my dogs don't bark. I just happen to get around them and I apologize for that. But so thank you for sharing that. And it's a wonder that we actually have people still doing the job. I think people forget, they think law enforcement's the most dangerous, but nursing and all this caregiving is very dangerous. So I hope we do fix it. And thank you for doing that work. Liz, I just wanted to add just a completely different regulatory space because I would be mad if I didn't say this in this space. What we did to support kind of wellness and nursing because they go through the same, we added to our mission in the regulatory space, nurse wellness is public protection. We have access to the Oregon Wellness Program, which, the nurse practitioner on here has spoken to. And we made sure we were engaged in the alternative to discipline program to make sure those that sometimes self-medicate, substance use disorder, mental health for depression because of this work would have access to an alternative discipline model. I know Todd is on here. Maybe he had to leave, Ray from the social work board. It's something that I try to think through how we can make sure all of those with mental health licenses and certificates have it too. It does come with kind of increase in licensing fees for the board, then spend that money. So that's why those places aren't in it, but I just had to say it here because my goal would be for every licensing board to be in it because some states do it that way. And then the cost is lower when everybody has to put in. So expect me talking about that more and more as an important piece of it. Doesn't take away all the stuff they go through, but at least there's something there for them.
No, I would love to hear more and more about that because what I see on the ground over and over is people being impacted by this work, getting depressed or getting back into substance use or anything like that. And then they're just abandoned and either fired or they have to leave the job because they're burnt out and not getting any support. So I'd love to explore like what you guys did and maybe bring that to the bargaining table next time. Thank you.
Mary, go ahead.
Just real quick, Liz, I appreciate what you said. And we talked about this in our training council. Our students are so vulnerable. Our students are the ones who we put them in placements and with some of the highest acuity, clients, and we just set them up for trauma and then we lose them, right? And I think it probably happens across all of our disciplines, and it's just being really mindful. And at the same time, we all want to develop a pipeline. So I think that not putting students in high acuity settings without sufficient supervision is something that's going to have to be really important as we consider this.
Absolutely. Yeah.
Thank you so much for bringing that up. I had the same question because just thinking about the pipeline and the workforce and how do people get the experience? Oh, go ahead, Alice.
Well, I just want to amplify what has been said. And Mary, what you said just, it reminded me a conversation that the First Lady and I had about the ways that and I'll just be vulnerable. I was directing our social work program and I felt really unprepared to support our students in the placements where they were getting injured. And it's like if educators don't know the wider context, then I mean, there's some moral injury going on here for all of us, but I'm not directing a social work program anymore, and I feel some relief at not having that kind of liability on my shoulders, but I'm really passionate about figuring out what needs to change and how do we fix some of these pipeline problems and by preparing people to and making sure that educators really understand the larger landscape. So I don't have any solutions, but thank you all to everybody who spoke today. I feel like blown away by what I've heard.
Same. Same, thank you. This has been an incredible meeting. Every meeting feels, I mean, just the learning and the expertise has been so helpful and so illuminating. We are at our time for today. Our next meeting is November 20th, same time, 2 o'clock. And what we have coming up is you'll get the agenda 48 hours in advance. We're moving through plans and I can't give you the definitive answer on the agenda yet because I think we're going to be ready to review some plans and we'll know soon. And so that, again, thank you for all of your diligence and your commitment and your time, both in these meetings and the meetings outside, and getting into the weeds on the action plans. It is deeply appreciated and look forward to seeing you later in the month. Take care, everybody.